Hi, I am Dr. Selvaraj, your surgical educator from Malaysia. Welcome back to my series of surgical teaching videocasts. These are meant mainly for undergraduate medical students doing their surgical clerkship rotation and all surgical trainees as well. I promise you will become competent in clinical problem solving and surgical decision making if you are going to watch these videos over and over again. Today, in this episode, I am going to discuss one more operative surgery procedure, that is how to operate or the various surgeries for fistula-in-ano. In the last video, I discussed surgery for anorectal abscess. One of the commonest complications after surgery for the anorectal abscess is fistula in ano. And in this video, I am going to discuss the various surgeries which we can do to deal with the fistula in ano. The first thing you must know in anal fistula is what are the various types of fistula that can develop. So this is same like anorectal abscess. This is also Park's classification. You can see the various types of fistulas here. Number one, A is superficial fistula or subsphincteric fistula. So this is A. See, it is not traversing or penetrating through both the external and internal sphincter. So this is subsphincteric fistula or superficial fistula. Then B is intersphincteric fistula. Here you can see the tract is going in between the external sphincter and internal sphincter, and it is penetrating only through the internal sphincter and opening inside into the anal canal. And the third variety is transsphincteric fistula, where the fistula will go and it will penetrate or traverse through both the external sphincter as well as the internal sphincter, and then the internal opening will be almost at the level of the dentate line in the anal canal. And the fourth variety is the suprasphincteric fistula, where this is the fourth variety, or D. This will go above both the external and internal sphincter. Then it will come down in between the external and internal sphincter. Again, this will penetrate or traverse only through the internal sphincter, and it also opens at the level of dentate line in anal canal. The fifth variety is extrasphincteric fistula, where the fistulous tract will go high up, almost at the level of levator ani, and this will never traverse or penetrate through both the external and internal sphincter, and the internal opening opens in the rectal canal. This is the only fistula where the internal opening will be very high in the rectum. So these are the 5 varieties of fistula that can happen in any patients. So another important thing you have to know about the internal opening, that is depending upon where is the external opening, that will decide where will be the internal opening. So we have to divide this anal area through a horizontal, this line, whichever fistula anterior to that, and if it is within 5 centimeter distance from the anal verge, then the tract will be radial like this. Okay, anterior fistulas. But if the distance between this external fistula and the anal verge or the tract is more than 5 centimeter, then even though the external opening is in the anterior to this horizontal line, it will take a curvilinear course and it will go to the posterior part and it will open in the midline. And all the external opening posterior to this line will also take a curvilinear course and it will open interiorly at 6 o'clock position. And this rule is called Goodsall's rule, whereby we can decide by seeing the external fistula, we can say where would be the internal fistula. Okay, that is this Goodsall's rule. The majority of these Fistulae-in-Ano arise from a diseased anal gland in the intersphincteric space. So this anal gland in the intersphincteric space has got an opening at the level of the dentate line, okay, and then through that opening, infection can go to this gland and this gland will become infected and an abscess will form. And this is called cryptoglandular abscess. The other causes of multiple fistulae are Crohn's disease, actinomycosis, hidradenitis suppurativa, and malignancy. Typically, we do the following surgeries for this Fistula-in-Ano. We do fistulotomy for superficial fistulae or subsphincteric fistula. For trans, supra or extrasphincteric fistulae, you have to do first put a seton. Initially, this seton is a draining seton. And then further treatment can be done either by putting a cutting seton or anorectal advancement flap or anal fistula plug or lift procedure, that is ligation of intersphincteric fistulous tract. These are the various surgeries available to treat Fistula-in-Ano. I am going to discuss one by one all these surgeries. So, surgery in this for Fistula-in-Ano, indication is Fistula-in-Ano, whether it is single or multiple, we have to do surgery. Anesthesia, we can give GA, spinal or epidural. Position is always better to keep lithotomy or sometimes jackknife position also can be used. Inform consent and then you have to explain the risk of surgery after, to get informed consent. Injury to the external anus sphincter and fecal incontinence comprise 30% of the complications. Recurrence of the fistula 10%. Bladder dysfunction again 10%. Bleeding and hematoma occasionally can happen, and anal stenosis also is a rare complication. So we have to explain all these complications to the patient and then you have to get a written informed consent from the patient. Pre-op preparation, examination of the patient under anesthesia is essential before planning for what surgery we have to do. Then you should also do digital rectal examination, proctoscopy to exclude Crohn's disease, tuberculosis, ulcerative colitis, and malignancy where there may be multiple fistulae. Endoanal ultrasound and MRI scan may be done for complex multiple fistulae. Enema should be given day of surgery, few hours before doing the surgery. Enema should be given. So the first surgery is fistulotomy. This is done for subsphincteric or superficial fistula. The position is just a lithotomy position. Then you have to do what is called bidigital palpation of the fistulous tract. For this, bidigitally palpate the perianal area from the external opening towards the anal opening. So you have to put your index finger inside and thumb. This is the external opening. From here to here, you put your thumb over this area and try to palpate. You can see that tract, you can feel actually. Not you cannot see, but you can feel it. And you can ascertain the type of the fistula. Is it intersphincteric or low transsphincteric? That you can ascertain. If it is just low transsphincteric or it is extra subsphincteric, then you can do what is called the fistulotomy. So you have to, what you have to do first, inject hydrogen peroxide into the external opening to find the internal opening. Before that, you have to put a anal speculum. You have to inject the hydrogen peroxide through the external opening. You can see the bubbles through the internal opening. After that, you can put a malleable probe into the external opening, which can come out through the internal opening like this. Here you can see. And okay, you have to cut this area from internal opening up to the external opening, or you can start from the external opening, you can go to the internal opening. Fistula should be laid open over the probe either by a knife or better to do it with diathermy so that any bleeding can also be controlled. Then after incising it, after fistulotomy, any granulation tissue in the tract, in this tract, can be curated by this curette. If it is an anterior fistula, we know the Goodsall's rule. It is, and within 2 centimeters from the anal verge, the tract will be a straight radial tract. That is what you are seeing here. Suppose if it is posterior fistula or even if it is an anterior fistula, if it is more than 5 centimeters away from the anal verge, then it will take a curvilinear tract and the internal opening will be at 6 o'clock position at the posterior anal verge. Yeah, here you are seeing this is a side tract where we are just cutting it. Here you are seeing a curvilinear course because it is a malleable probe. You can, I mean, somehow you can go inside and the tract also will be a curvilinear course. You have to incise this just over this probe. Yeah, this is fistulotomy. So coming to the next, that is Seton, that is draining. So first inject, like the previous procedure, hydrogen peroxide into the external opening to find the internal opening. Probe the whole fistulous tract with a malleable probe. Transsphincteric, suprasphincteric, and extrasphincteric fistulae initially treated with draining Seton and not fistulotomy. Because in all these fistulae, if you are going to do a fistulotomy, you will be injuring both the external sphincter and the internal sphincter, and the patient will end up with fecal incontinence. So we should not do fistulotomy for all these 3 types of fistulas. We should do initially put a draining Seton. Seton, how to place. After putting this probe inside, you tie a silk thread here, pull this malleable, probe outside so that the silk thread will go inside. Then tie the end of the Seton to this silk thread. Again pull the Seton through the tract. Now the Seton should be secured with a square knot. Here you can see. And then tied with silk. Put a square knot there, then you have to tie, and then the excessive length you have to trim it. For horseshoe-shaped fistula, here you are seeing, see, this is the Seton inside, and externally put a square knot and tie it with a silk knots. For suppose if it is a horseshoe shaped fistula, you can use Penrose drain as Seton. You are seeing it in this picture. Coming to the Seton cutting, you have to remove that draining Seton first. After the placement of draining Seton, closure of the fistula can be accomplished by one of the three ways. Either you can do it by cutting Seton, an anorectal advancement flap, or a fistulous plug. So here in this slide, I am going to describe how to do a cutting Seton placement. So you have to remove the draining Seton first. Remove this one. And then you have to put a probe inside. And how to place the cutting Seton. Silk is pulled through the tract after cutting non-sphincteric tissues. So the probe is there, then you have to cut it like fistulotomy, but only the mucosa you have to cut. Don't cut the muscular layer. That means cutting only the non-sphincteric tissue. Then the Seton is pulled through the tract. Yeah, tie the silk thread first, pull the silk thread, then after tie a Seton to the silk thread and pull the Seton also. Then we have to tie the Seton snugly like this. Then we have to tighten on follow-up in the outpatient clinic in 3 weeks interval. Once in 3 weeks time. So first time we have to tie it here. The second week here. This is the third week. So you have to keep on tightening it. What will happen? Slowly this sphincter will be cut by this Seton progressively. So it is not all this sphincter is not going to be cut at the same time. Slowly it will be cut. So whatever sphincter is cut in the upper part, that will get healed by the time you are going to, tighten this in the next, after 3 weeks interval. So only once in 3 weeks we are going to tighten it. So meanwhile, whatever cut sphincter is there in the upper part, that will heal. This is to avoid fecal incontinence. Anal sphincter will be cut by cutting Seton over a period of many weeks. It is not all of a sudden. So this is how the cutting Seton is worked. The next procedure is anorectal advancement flap. This also we can do. First thing is you have to elevate a mucosal flap. Anorectal mucosal advancement flap works well when the tract of the fistula is short and narrow. After passing a fistula probe through the fistulous tract, the draining Seton is removed. Beginning distal to the internal opening and in proximity to the dentate line, a curvilinear incision is made in the mucosa using a scalpel here. You have to make a curvilinear incision like this. Then elevate the mucosal flap. Here they are elevating it and separate it from the underlying internal sphincter. You are seeing the internal sphincter muscle there. Only the mucosal flap you have to elevate. Then the second step is closure of the fistula and advancement of the flap. The defect within the internal and external sphincter muscle is closed longitudinally with interrupted 3O absorbable sutures. Here you are seeing it clearly. We are closing it longitudinally with interrupted 3O absorbable suture. Maybe you can use Vicran. The internal fistula opening within the mucosal flap is excised. Here you are seeing it clearly. The mucosa is approximated to the distal anoderm using again 3-0 absorbable suture material. See, this flap is again sutured here. That is what you are seeing here. So this is what you have to do. After this procedure, sometimes you can do diverting ileostomy to save this part for some time. Temporary ileostomy also, some of them are doing. So coming to the anal fistula plug, first is similar to the previous procedure, you have to remove that draining seton. A fistula in ano that involves a significant portion of internal and external sphincter muscle, that is the transsphincteric fistula, can be repaired successfully with a porcine anal fistula plug. So inject hydrogen peroxide to define fistulous tract. That is the first step. Remove the draining seton after probing the tract with a malleable probe. Pull the silk thread through the tract with the help of the malleable, the probe. Then you have to place that porcine fistula plug, tie the porcine plug to the silk thread and pull it into the fistulous tract. You can see it. See, they are tying it here and they are going to pull it through this fistula. 3O absorbable vertical mattress suture are placed through the anal wall and fistulous plug. You are seeing here, this is the mattress, suture you have to put. When these sutures are tied, the internal opening should be completely covered by mucosa. If you are going to put a suture like this, the internal opening will be closed by mucosa to prevent infection due to leakage of bowel contents into the fistulous tract through the internal opening. The fistula plug transected flush with the skin at the level of external opening here. So this tract will be occluded by this porcine fistulous plug. This is a best procedure because we are not creating any wound. We are just plugging it. So another recent advance is lift procedure, or this is also known as ligation of intersphincteric fistulous tract. So after removing the draining seton, okay, you can do this procedure. What you can do, it is the indication is transsphincteric fistula. Draining seton should be there for 6 weeks time. After that, you remove the draining seton and then we have to intersphincteric mucosa in between the external and internal sphincter. You can feel a small depression. In that area, you make an incision. Go inside until you are going to see that fistulous tract. Just separate it and then you can just put two ties and then you can divide it. The tract should be prepared with fistula brush. You can debride and de-epithelialize the tract also. So this is what you are seeing here. This is a closer picture. The same thing. So you have to identify the fistulous tract. Then you have to, you have to ligate it and then you have to cut it. Before doing the ligation, you can just de-epithelialize and debride the tract also. Okay, this is the lift procedure, ligation of intersphincteric fistulous tract, which you have to dissect in between the external and internal sphincter. You go deep and find out the tract. Coming to the complication, incontinence due to injury to external sphincter accidentally during surgery. I've already told you 30% of the patient. Bleeding, if severe and persistent, need to be controlled in OT. So you have to take the patient to the OT, you have to control. Wound infection is 10%, bladder dysfunction also 10%, that is the acute retention of urine in very few patients. What is the post-op care? Daily we have to give 6 baths after each bowel movement. Daily dressing of the surgical wound also must be done. Digital rectal exam at discharge and after 1 week to prevent adhesion between the raw areas. Oral analgesic tablets as needed can be given. Mild oral laxatives for 2 to 4 weeks post-operatively should be given. Patients can be mobilized immediately after surgery. You can give time off from his work to 1 to 3 weeks time. You can give, leave for these patients. So thank you very much for watching this video. If you think that these videos are very helpful, kindly share them in your social media. Kindly click the bell button also to get notified regarding my all recent uploads. Thank you once again for watching this video. If you think that these videos are really helpful, kindly share, subscribe, and like this channel. Bye bye until we are going to see once again. Bye bye.